Hello, everyone. I'm really happy to be with you here today. This is part 2 of our series, Billing Codes for CDAPP Sweet Success Patients. My name is Marianne Hodorowitz. I'm a registered dietitian nutritionist. I have my MBA from Loyola University in Chicago with a focus on marketing. I'm a certified diabetes care and education specialist, and I'm a certified endocrinology coder. Strange combination of credentials, but it works for me. Okay, and there's a little bit of a bio, and my contact information is at the bottom. Here's my disclaimer. Basically, this says is that this webinar is for educational and reference purposes only. It is not legal, financial, medical, or other professional advice, and to seek interpretation is subject to legal representatives and end users and recipients. And you should really seek professional counsel for legal, ethical, and business concerns. And just so you know that insurance companies change their guidelines practically every single day. So even though this PowerPoint has been updated for the latest guidelines for billing for pregnancy, which you're all involved in, insurance companies could change their guidelines at a moment's notice. That's why you really have to keep up with insurance billing guidelines. Okay, let's look at universal codes. Maternity services can potentially use 5 sets of universal codes on claims. ICD-10, and it used to be ICD-9, now it's ICD-10, and that's for diagnoses. CPT, and that's for procedures. HCPCS, and that's for procedures, medical goods, and services. We'll explain all this in a minute. Revenue codes, and that's just for hospital claims. And then evaluation and management codes, we call those E&M. Okay, CPT codes, that stands for Current Procedural Terminology Codes. These are a group of procedure codes used in medical billing. They're created and owned by the American Medical Association, and they're used to standardize reporting of medical, surgical, and diagnostic services and procedures and serve as a common language between providers and payers. They're the most commonly used codes on claims. Now, there's 3 types of CPT codes, Category 1, Category 2, and Category 3. Let's look at all 3 of them. Each CPT code represents a written description of a procedure or service and eliminates any subjective interpretation of what was actually provided to a patient or a client. And they help payers and researchers measure health data, the value of services, the quality of care and performance, and how efficiently medical care is delivered. Okay, let's look at the difference between Category 1, 2, and 3. Category 1 codes are always numeric, always numeric. They don't have any alphabets before them. They have an assigned relative value units or RVUs, which is the same as saying work values. And those work values have associated payment amounts. And then we got the Category 2 codes. These are not billable for reimbursement. They're called tracking codes to facilitate data collection related to quality and performance measurement. You can see at the bottom, like 3044F, that would be for an A1C level of less than 7%. 3045F is an A1C of 7.0 to 9.0, and 3046F is an A1C of greater than 9. So, it's important for providers and health insurers to track certain health data so that better guidelines can be created to help patients with their health care. But these are not billable for reimbursement. So here are a number of Category 2 ranges. You can see they address all different parts of the body. Anesthesia, musculoskeletal, respiratory, cardiovascular, digestive, and again, they're optional. Providers do not have to put these on claims, but sometimes the insurance companies who are paying your claims will ask you to put these on claims. And if they do, you should really comply with that because, they're paying your claims. And if they say, please add this, because we're trying to track this kind of data to give so that we can help our subscribers with better health care, I strongly suggest that you comply with their request. Category 3 CPT codes are reimbursable, and they're alphanumeric. They always start with a letter, and they're used to report emerging technology including services or procedures that are new and emerging on human and clinical trials. And a lot of them are considered temporary codes, and they have to be accepted for placement in level 1 within 5 years, or be renewed for another 5 years, or be removed from the CPT book. Okay, what about HCPCS codes? Whoops, sorry about that. Okay, HCPCS are called Healthcare Common Procedure Coding System, and these are alphic and numeric. Again, they start with a letter, and then they're followed by numbers. And they allow the use of uniform reporting on items and services that are medical in nature, and these are not included in the CPT manual. And they're used to code prosthetics, orthotics, drugs, injectables, casts, transportation, and patient education. And this is what I'm involved with as a diabetes educator. G0108 is individual diabetes self-management training, and G0109 is group diabetes self-management training. Revenue codes. Now, revenue codes are 4-digit numbers, and they're only used on hospital UB04 claims. And they tell insurance companies where the patient was at when they received the treatment. Was the patient in the emergency room, the operating room, or another department? And they also tell the insurance company what type of item a patient might have received as a patient. A hospital claim will not be paid if this code is missing. Now, the revenue code and the corresponding HCPCS or CPT code must be compatible. Okay, so your claims people have to refer to the most current uniform billing editor for the most appropriate code sets. So outpatient facility and hospital claims will likely be denied when received without a corresponding HCPCS CPT code associated with an appropriate revenue code. And again, the CPT or HCPCS code has to be associated with the revenue code. Otherwise, the claim will be denied. And again, the revenue code says where the patient was. Like an example at the bottom was when the patient came in to remove the stitches, were the stitches removed in the ER or the outpatient clinic? If they were removed in the ER, that's probably going to have a higher cost associated with it versus the stitches removed in the outpatient clinic. So in the ER, that claim will probably get a higher amount paid versus the outpatient clinic. So you can see here a whole list of revenue codes. Okay, we've got about 3 pages of them. Okay. Okay, so what you need to do, order current coding manuals. Again, these codes change every single year. So if you're involved in billing and coding, you have to have the current coding manuals. And a lot of times what billers and coders will do, they'll just go online into Google or Bing and try to look up things online. That won't work. You've really got to get the manuals. And you know, the manuals can be pricey, but your facility should pay for that. And then review the current CPT code changes to the guidelines and notes and instructions. Highlight the changes in the manual with yellow highlighters and review those changes. And even if you have to create a cheat sheet so you can then study what's changed and get that in the forefront of your mind, and then review and update your super bills when applicable. Okay, so now let's look at coding and billing methods for what you do. There's 2 types of OB coding and billing methods that exist now: global and bundled OB care codes, and non-global, non-bundled OB care codes, or codes for partial services. Now we're getting into the meat of what you do. Okay, first of all, who is eligible for billing? Who are eligible billing OB providers of patient care? Eligible billing providers of obstetric medical patient care: obstetricians, maternal fetal specialists, certified nurse midwives, nurse practitioner midwives, certified professional midwives, except residents who are not billable providers. So those 4 different types of providers listed there can bill insurance companies for obstetrical care, except residents. They are not billable providers of obstetrical services. Okay, let's look at evaluation and management E&M codes. E&M codes, excuse me, The criteria for E&M code selection in 2021, and we'll talk a lot about E&M codes today. E&M code selection will be based on either the level of medical decision making or the time for performing the service on the day of the encounter. So either the level of medical decision making or the time that was on the clock on the day of the encounter. Okay, E&M codes, evaluation and management, are used for the management of conditions unrelated to the pregnancy. Now, sometime what I did here is I put in red font and I yellow highlighted things that are really important. Again, E&M codes are only used in a claim for the management of conditions unrelated to the pregnancy during the antepartum and or the postpartum care. So for example, if you're managing the patient's diabetes, hypertension, cardiac problems, hyperemesis, I had that when I was pregnant both times, preterm labor, bronchitis, asthma, urinary tract infection, I had that too. That's when you're going to be using the E&M codes because those are unrelated to the pregnancy. Okay. So when we talked about how you choose an E&M code, there's E&M codes for a new patient office visit, and you can see here in the blue table, they end in 01, 02, 03, 04, and 05. Okay, that's new patient. And so how you select it is on medical decision making or the typical time. So the 01, the medical decision making was problem focused, 02 was straightforward, 03 was low, 04 was moderate, 05 was high complexity, or the typical time, 10 minutes all the way up to 60 minutes. So you either use medical decision making to select the E&M code or the typical time. Now the other set of E&M codes end in 11, 12, 13, 14, or 15, and this is for an established patient visit. And again, how do you select 11, 12, 13, 14, or 15? It depends on the medical decision making, low, moderate, or high complexity, or on the typical time you spent, 20, 30, 45, or 60 minutes. The higher the level of E&M code, generally the higher the level of reimbursement. Okay, so again, individual E&M code should not be billed to report a pregnancy-related E&M visit unless it's instructed by your insurance company or the payer. Okay, so the next slide is a listing of common OB maternity complication diagnoses. Now this is not an all-inclusive list, but it gives coders an idea of diagnoses and symptoms that may place the patient in a risk diagnosis area. So again, some of these complications may warrant an E&M code because these can be unrelated to the pregnancy. But again, E&M codes, if you're tempted to use them, you really want to check with your payer, your insurance company, because the last thing you want to do is put an E&M code on the claim and have the claim denied and then have to go through the appeals process. We talked about this in the first webinar, because that can be time-consuming and costly. It costs you a lot of time and money. Okay, let's look at global bundle codes for all OB services. Okay, maternity OB codes that bundle OB services in one package to allow providers to bill one single CPT code for all three types of OB care: antepartum, delivery, and postpartum care. I call that ADP, antepartum, delivery, and postpartum care. Okay, so this is the most common way now to bill insurance companies using one single CPT code that bundles all the care you give in the antepartum, delivery, and postpartum care for the woman who's in your practice situation. Okay. However, there are times when an OB patient receives services that do not fall in the global package, or complications arise that require separate codes for partial services. So let me really emphasize here, the two ways for billing is this global bundled code. So everything you do is bundled into one CPT code for ADP, or you're billing for partial services because the services you're providing the woman do not fall into the bundled code. We're going to talk about that now. Again, most payers reimburse for routine OB professional services based on this global or bundled package of services rather than itemized charges for partial services. Okay, and the global bundled packages apply to routine care provided to the patient during the antepartum, delivery, and postpartum periods for uncomplicated pregnancies. And most insurance companies reimburse now providers based on this one global bundled OB maternity code for uncomplicated pregnancies. So it's antepartum, delivery, and what is delivery? Intrapartum care or labor and delivery, and postpartum care or ADP. Now, all routine prenatal visits, and roughly 13 is typical. That's going to come back again. How many prenatal visits is typical? About 13. And when it goes less than that or more than that, we're going to have different codes. So about 13 prenatal visits is typical until delivery for uncomplicated cases. Okay, so antepartum services included in global care: your initial and subsequent history and physical exam, recording of weight, blood pressures, and fetal heart tones, and routine chemical urinalysis. So even though we have CPT codes here at the bottom of the slide, you don't list those CPT codes because this is included, that the chemical urine analysis is included in the global code. Okay, also included in your global bundled code is delivery, and that begins on the date of initial hospitalization for the delivery and extends through the date in which the patient was released from the hospital. So yes, when the patient's admitted to the hospital, this is included in the global code, your payment, and it goes through when the patient's released. So hospital care, look at the bolded print here, hospital care related to the delivery is considered part of the delivery charge and part of the reimbursement, and is not considered part of postpartum care. So delivery services include the following and is not billed separately: admission to the hospital, admission history and physical, inpatient evaluation and management services provided within 24 hours of delivery, so you're not billing separate E&M codes. Number 4, management and fetal monitoring of uncomplicated labor, and that includes external and internal fetal monitoring provided by the attending physician. And number 5, management of uncomplicated labor, vaginal delivery with or without episiotomy, and with or without forceps or cesarean delivery. It also includes intravenous induction of labor via oxytocin. Even though I've got CPT codes there, you don't use those because this is included in the global bundled code. Number 7, delivery of the placenta, any method. Number 8, repair of first or second degree lacerations. A little more information on that on the next slide. Insertion of a cervical dilator to be included if performed on the same date of delivery. And number 10, vaginal cesarean section delivery, delivery of the placenta only. Now the above mentioned on the red at the bottom, these above mentioned services are not separately reimbursed when reported separately from the global OB code. Again, all of this is included in the global bundled OB code. Okay. Now, again, always checking with your insurance company is the best thing to do. You can see here in red, the third bullet point down, repair of first or second degree lacerations. I have here, or use CPT intergumentary section code, or by adding modifier 22 to the delivery code reported to the global OB code. Check with insurer. When I did my research to prepare this deck, some of the insurers are requiring this red area that you see here that I outlined in red. They remove it from the global bundled code and want you to report these separate CPT codes, or add modifier 22 to the global OB code, because modifier 22 means that there was increased services, there was increased effort or increased services extended by the practitioner on behalf of the patient. That's what modifier 22 means. So again, you have to always check with the insurer, okay? If you look at the second from the bottom, bullet point down, what else is included in the global bundled code? Routine outpatient E&M services provided within 42 days following delivery. So again, you're not using separate E&M codes. And then at the last bullet point, postpartum care after vaginal or cesarean section delivery. Even though there's CPT codes for that, that postpartum care after delivery is included in this global bundled code. Okay, what about postpartum services, that's included in the global bundled code? Uncomplicated inpatient visits following delivery. Okay, we already talked about the second bullet point in red, repair of first or second degree lacerations. Check with your insurance company. Simple removal of cerclage, not under anesthesia. Routine outpatient E&M services that are provided within 6 weeks of delivery. Again, check with your insurance guidelines for the exact postpartum period. Discussion of contraception prior to discharge. Outpatient postpartum care. And educational services like breastfeeding, lactation, and basic newborn care and nutrition, and uncomplicated treatments and care of nipple problems and/or infection. So a lot is included in that postpartum global bundled code. So when does the postpartum care services begin? It begins after the patient is discharged from the hospital stay for delivery, and it extends throughout the postpartum period, which is 56 days for vaginal delivery and 90 days for cesarean delivery. Okay, how does the AMA define global obstetrical care? The total obstetric package includes the provision of antepartum care, delivery, and postpartum care. It's according to the AMA CPT code book. Okay, so here are the global and non-global codes. Again, you're saying, Marianne, why are you giving these if you're saying that most insurances want the global codes? Because again, let's look at the first red box. If your insurance company says, no, we want you to bill outside of the global codes, like if your patient has vaginal delivery, we want you to bill the vaginal delivery CPT code. So you can see here it's 59410. They don't, or the 59409. Vaginal delivery only, with or without episiotomy and/or forceps, or 59410, vaginal delivery only, including postpartum care. So, but again, most insurances want that global billing. But I've given you the codes here in case they want you to bill separately outside of the global billing. Okay. So just as a reminder, global bundled services at the bottom include antepartum, delivery, and postpartum care. Okay. So for billing purposes, obstetric period begins on the date of the initial visit in which pregnancy was confirmed and extends through the end of postpartum period, and that's 56 days after vaginal delivery and 90 days after cesarean section. Okay, let's look at the requirements for billing one global bundled code. To bill the one global obstetric package CPT code, all services must be provided by one practitioner, one obstetrician, one midwife, or by the same physician group practice that provides all of the patient's routine OB care, and that includes ADP. So one practitioner or the same physician group to bill that one global code. One practitioner or by the same group. And remember, that bundled global code, that includes roughly 13 antepartum or prenatal visits. Now, the number of antepartum visits we know can vary from patient to patient, okay? But it also includes delivery and postpartum care. Okay, how does insurance companies then define same physician group practice? It's defined as a clinic or an obstetric clinic that is under the same tax ID number, or it uses either an EHR or one hard copy patient record, wherein each physician, NP, or nurse midwife seeing the patient has access to the same patient record and makes entries into the same record as services occur. So this is important why I define this, because if your insurance company comes to audit your practice, they want to make sure that your patient is really being seen by that same physician group if you're using that bundled code that they told you to use. Okay, very important. This is interesting too, the breakdown of the OB Global Bundled Code 959400. Antepartum care was 41%, intrapartum was 36%, and this includes history and physical and labor management, vaginal delivery 15%, postpartum care 8%, and that includes postpartum inpatient and outpatient visits. Again, here's your global and non-global codes. And again, the reason I included non-global codes in case your insurance company does not want you to use the global. Okay, so this is the introduction to partial only codes. When global codes cannot be used. If the services rendered do not meet the requirements for total obstetric package, insurers are going to require the use of standalone separate CPT codes for antepartum care, intrapartum delivery care only, or postpartum care only, or delivery and postpartum care only. So those are like all separate, right? Okay. So let's give examples of these situations. The patient has received part of her antenatal care somewhere else from another group practice. The patient leaves her care with your group practice before the global care is complete, or the patient receives care from a midwife and later requires an MD level care, or the patient has a change of insurer during her pregnancy. All of these situations is going to mean that the global code is no longer appropriate and that you're going to have to bill the separate CPT codes, and you're not going to be billing the global codes. Let's look at more examples. The patient transfers into or out of a physician or group practice because she moved out of state. The patient referred to another physician during her pregnancy. The patient has delivery performed by another physician or other healthcare professional not associated with her physician group practice, or the patient terminates or miscarries her pregnancy, or the patient changes insurers during her pregnancy. Again, that's when you're going to have to bill partial care codes and not the global code. Okay, when else do you bill partial codes? When the number of antepartum care visits are different than 13. Look at this table here. The very top, the very first column, the number of antepartum visits, 13 is the average number in uncomplicated OB care. And that's typical in your global code for antepartum care, intrapartum, and postpartum. 13 is roughly the average number. But let's look at the second row. Less than 3, then now you're billing the appropriate E&M codes. 4, okay, now you've got different codes now. You've got partial only. You've got 59400, 595, 10, 59610, 59613, only because you've only got 4 antepartum visits. And you can see, I'm not going to read through the rest of these rows, the last 3 rows. So the number of antepartum visits will determine which codes you're billing on your claim. And that's right there. Okay? You can see, let's see here. Oh wait, let me get my cursor so you can follow along my cursor. 1, 2, 3. You can see right here, 59425. Antepartum care only, 4 to 6 visits. 59426, antepartum care only, 7 or more visits. Remember, 13 is average. This is where you're billing partial services because your antepartum care is not 13 at this point. So you're away from the global code. Okay. Okay, so this is billing only antepartum care services greater than 14 visits due to complications of pregnancy. So you're billing this separate code right here, and you're adding 22 modifier to indicate increased services. Why? Because you've got 14 antepartum visits where usually it's only 13. Now, be sure to have documentation, such as a progress note or an antepartum flow sheet, that clearly describes the medical necessity for that extra antepartum visit. Because again, if you get audited and you don't have clear documentation, you may have to give all that reimbursement back, and you're saying, well, that's not a big deal. Well, they can charge you penalties and fines, and that is a big deal if you have to pay penalties and fines. That's not a good thing. And then your insurance company may then decide not to credential you next year because they could feel that you're purposely defrauding them. Okay. Okay. Let's look at that bottom bullet point. When documentation supports medical necessity of additional visits, some payers will reimburse an additional $55 for those additional visits, because 13 are typically included in the global package. But again, if you have medical necessity for 14 or more, you could get paid that extra money, but you got to have proper documentation. Okay. Again, if you have in a range of 7 to 14, you've got different codes you have to bill, and append the modifier 22, and then you can follow my cursor, you can get additional reimbursement. Okay. Here's just another table for your benefit. Antepartum care only, 1 to 3 visits, 4 to 6, 7 or more, and then you've got the different CPT codes. This is when you're not billing the global code. Okie dokie. And here is your table again. Okay, what about billing only delivery codes? Again, this is when you're outside of the global billing. So if a C-section is performed, reimbursement for delivery only charge includes payment for surgical procedure as well as a post-surgical care. Vaginal delivery only, you can see the code here, C-section only right there, and VBAC delivery only right there. And you're saying, well, Marianne, I thought you told me to bill the global code. Well, yeah, but remember, what if you can't bill a global code because a patient has switched a physician practice, or you've got two different physicians treating the patient? Remember, there was conditions for billing that global code. The patient has to be in the same practice or seeing the same physician. Okay. Okay, billing only delivery codes. Delivery of multiples. Okay, bill appropriate delivery code, and that's determined by the method of delivery for baby A, 1 unit, add modifier, 22 modifier for increased services, and you've got to have documentation showing the method of delivery for each baby, and that's considered a complicated delivery, and you got to add the modifier 22. Okay. Okay, let's look at gynecological surgeries. For gynecological surgeries, the global period differs based on the surgery. Okay, for billing purposes, it begins after the patient's discharge from the hospital stay for delivery, extends throughout the postpartum period, 56 days for vaginal, 90 days for cesarean delivery. For postpartum care only, bill 59430, but always check first with the payer. Again, this is if you're billing postpartum care only, because the patient is seeing more than one physician, or she's changing physician groups, and you can't bill the global code. And you're billing partial OB codes. You're outside of the global code. Okay, and this is what this slide is all about. You have these partial OB codes. Check with your insurer first. Okay, here are services not included in the global OB package that generally you can bill separately. Laboratory tests beyond the routine urine analysis, fetal contraction stress test and fetal non-stress test, management of surgical complications during pregnancy, obstetrical ultrasounds, but the E&M visit, which is not separately billable unless modifier 25 requirements are met. Okay, so this is usually not included in the global package, but can be billed separately. Okay, and so when you're seeing the patient to discuss the results of all this, you are billing right down here, the E&M visit. okay? But you've got to add the modifier 25. Okay. Okay, these services that we talked about usually occur during antepartum care, but are not inclusive to the global OB package, but may be billed separately. Check with each insurer first. Obstetric ultrasound, echocardiography, I don't know how to pronounce that, external cephalographic version done in the clinic, fetal biophysical profile. You can tell I'm not in the OB world. Administration of Rh immunoglobulin, amniocentesis, fetal non-stress test, thyroid testing, blood typing and Rh factors, routine OB maternity laboratory services such as HIV testing, blood glucose testing, sexually transmitted disease screening, and antibody screening such as rubella or hepatitis. That's usually not included in global OB package billing. Complications of pregnancy, evaluation and management services for problems unrelated to pregnancy. Again, this is where you build the E&M codes for complications unrelated to the pregnancy. Lab test performed outside of routine chemical urine analyses, surgical complications and other problems related to the pregnancy. We talked about all this before. Okay. Okay, here's another whole list of services not included in the global packaging. I'm not going to read all this for the sake of time because you're going to have this deck in front of you. I just want to go over this bottom one, obstetrical ultrasounds, but E&M visits not separately billable, again, unless you add modifier 25 if the 25 modifier requirements are met. The modifier 25 indicates increased services to indicate that the care provided is significant and separate from routine antepartum care. Okay? So that modifier, the use of modifiers is important. It tells the payer that increased services were necessary as part of the health and well-being of the patient. Okay. What else is not included in the global package? Inpatient E&M services provided more than 24 hours after delivery, surgical procedures during pregnancy. Okay? Laceration repair of third and fourth degree. Now, I'm going to ask you, because we had this on another slide, to check with your insurance company. Some payers include laceration repair in the global package. Some do not. This was on another slide. Some include laceration repair, some do not. So again, check with your insurance company on laceration repair. Now, we talked before about greater than 13 antepartum visits. We had a couple slides on what you do when you have greater than 13 or less than 13. Those are billed outside of the global package. You have to use separate codes. Okay, so again, we had a couple slides on services that are not included in the global package, and this is just a repeat of those slides. And this is a repeat too. E&M services for management of conditions unrelated to the pregnancy, like diabetes, hypertension, and again, you're going to be using E&M codes for these if you're treating these conditions, because they're really not related to the pregnancy. The patient could have diabetes before she even got pregnant, or hypertension before she got pregnant. And of course, the pregnancy will exacerbate these conditions, and this is where you're going to use E&M codes to treat these conditions. So if the patient requires services outside of the OB package, it is appropriate for coders to bill from them. Okay, absolutely. And coders should assign appropriate E&M codes, either new patient E&M or established patient E&M, to reflect the separately identifiable service. Okay. And then remember, you have to put the right diagnosis down on the claim. For diabetes, infections, heartburn, insomnia, not just the procedure code like the E&M procedure code, but also the right diagnosis. Coders should always bill for procedures not bundled with the maternity package deal at the time of service. Providers may perform these procedures during routine antepartum OB visits or schedule them as separate identifiable visits. Providers should not bill a separate E&M visit performed on the same day as a planned procedure. We talked again that additional E&M visits for complications or high-risk monitoring resulting in more than 13 antepartum visits those are not included. More than 13 antepartum visits are not included in the global OB package, but there's different ways to bill for that, and those were included on other slides in this deck. Okay, these additional E&M visits, if you have to bill additional E&M service visits, they should not be billed until after the patient delivers. Add modifier 25 to identify these visits as separately identifiable from routine antepartum visits. Inpatient E&M services provided more than 24 hours before delivery, management of surgical problems arising during pregnancy, these are not included in the global package. Appendicitis, ruptured uterus, these are billed separately. This is not included in the global package. Again, the OB package works well for patients who see the same physician for the entire duration of the pregnancy, delivery, and postpartum care. But there are times when this is not the case or other complications arrive. So let's look at some tips when billing alternate or non-traditional OB maternity situations. The patient transfers into or out of a physician practice group, then the global codes don't apply, is referred to another physician during her pregnancy, has her delivery performed by another physician or another professional not associated with her initial physician or group practice, terminates or miscarries her pregnancy or changes insurance companies. Then you're into these separate CPT codes for what we call partial services. Okay, here's billing scenario number 1. Patient received antepartum care with Dr. Smith. Dr. Jones, who is in the same practice with Dr. Smith, provides the delivery. Dr. Smith does the postpartum care. Coders should code and bill the entire package under the patient's primary physician using the global maternity package, because Dr. Smith and Dr. Jones are in the same practice group, so the global maternity package can be used. Okay. Let's look at scenario number 2. Patient receives antepartum care with Dr. Smith, but Dr. Dumore, who is unaffiliated with Dr. Smith, provides the delivery care, and Dr. Smith does the postpartum care. Coders should bill for the antepartum and postpartum services provided by Dr. Smith, but Dr. Dumore bills for delivery. So Dr. Dumore is going to bill for delivery with separate CPT codes, but not the global because he only did the delivery. But Dr. Smith is going to bill for the antepartum, but that's going to be a pull-out separate CPT code for the antepartum, not the global, because they didn't provide all the services in the global. So now you can see with this scenario why we have to have separate CPT codes for delivery and separate global codes, because this patient was seeing different doctors for antepartum and delivery and postpartum. Okay, scenario 3. Dr. Smith provided all the services for vaginal delivery. Dr. Smith performs a sterilization procedure post-vaginal. Coders should code and bill the package first, and then bill the correct CPT code for sterilization services provided during the post-vaginal delivery within the maternity stay. So yeah, the global code pertains here because it was one doctor who provided everything, but we have the sterilization services, which is not part of the global code. And so we have a separate CPT code for sterilization. Let's look at scenario 4. Dr. Smith provided all the services for a C-section delivery package code. In addition, performed sterilization immediately after C-section. So we have to bill the package first, the global package first, and then the CPT code for sterilization. Okay, scenario 5. Dr. Smith provided all the services for vaginal delivery, and Dr. Dumore repairs a 4th-degree laceration to the cervix during delivery. Coders code and bill for Dr. Smith's services the global package. Dr. Dumore bills separately for laceration repair. Okay, because for that laceration repair, when I researched this, it said in my research that laceration repair, this confused me. Some insurances require separate CPT codes for laceration repair. Other insurances include laceration repair in the global package, in the global code. So I'm strongly suggesting you check with your insurance company for how to code for laceration repair. And I'm sorry if I'm confusing you, but in my research, I had 2 different results when I looked up about laceration repair. Okay, how do you code for multiple gestations? The accepted norm for these services is to bill a global package code for the first baby and delivery only code for the second or subsequent babies. But some payers have specific billing requirements for these services. If both twins are delivered via cesarean delivery, bill code 59510, and that's routine obstetric care, including antepartum, cesarean delivery, and postpartum care. This is because only one cesarean delivery is performed in this case. However, if the cesarean delivery is significantly more difficult, add modifier 22 to code 59510, because again, that modifier 22 means it was more difficult, it required more effort. Okay, and when you report modifier 22 with that code, a copy of the operative report is to be submitted to the insurer with the claim. Okay. Okay, so vaginal delivery of twins, twin A, here's the CPT code. These are global codes, by the way. Twin B, here's the global code with the 59 added. C-section delivery, twin A and twin B, that's C-section. Here's the global code. Repeat cesarean, here's the global code. Okay. Modifier 59, distinct procedural service used when 2 procedures are bundled and modifier is allowed. Okay. Whoops. Sorry about that. Okay. So this is just another coding example. I think we were running through this. VBAC delivery of twins. Okay, here's your code. Twin A code, twin B code was 59. Vaginal and C-section. Here's your codes right here. VBAC and repeat cesarean, your codes and your codes. Modifier 51, when multiple procedures other than E&M, physical medicine, and rehabilitation services or provision of supplies are performed at the same time by the same provider. Okay. Some payers preferred the above method on the prior slide, however, would rather the coder bill for one package code with modifier 22, increased, again, some payers want the package code, the global code with modifier 22. This is for twins. Modifier 22 means increased services because you've got twins, and increase the billed dollar amount by 25 to 40% based on how many babies were delivered. Check with your insurer first. What about coding for high-risk pregnancies? In high-risk pregnancies, the mother and the baby may be at increased risk. This special monitoring or care may require more than 13 prenatal visits. Okay. Okay. Visits for high-risk pregnancy are not considered routine. They should be reported in addition to the global OB CPT code. This is your global codes, okay? But the provider may bill additional EM codes along with modifier 25 to indicate that the care provided is significant and separate from routine antepartum care. This is when you've got high-risk pregnancies. You are billing the global code, but you're billing additional E&M codes because of the high risk, and you're adding modifier 25 to tell the insurance company that the care is significant and separate from the routine antepartum care. Okay? And then here's an example of diagnosis codes. This is diagnosis codes now, not CPT. Supervision of high-risk pregnancy, pre-existing hypertensive heart disease. This is, again, none of these may actually apply to your patient. This is just an example of some diagnosis codes for high-risk pregnancies, because the diagnosis code has to go on the claim also. Tips for coders. Coders should feel confident coding nearly any OB maternity case, follow CPT guidelines, correctly append diagnoses, contact insurance companies for their input, and ensure physician documentation of all three phases: antepartum, delivery, and postpartum care. Providers should not bill above listed global services separately, as they're bundled as part of routine OB care visits. These services are not reimbursed separately when reported. These bundled services are not reimbursed when reported separately from the global OB code. To ensure correct payment, providers need to work with their medical billers or billing and coding company to identify all potential bundled payers that they require before billing. So again, check with your insurance company if they're requiring the bundled codes. Now again, those E&M codes, they can be very confusing. They should not be billed to report maternity visits except when the patient presents for issues outside of the global package, when they're having complications, when there's less than 4 antepartum visits, okay? And you can add modifier 25 to the E&M code to indicate that the visits are outside of the global surgical period. Okay. 25 is defined as a significant, separately identifiable E&M code by the same physician or other qualified healthcare professional on the same day of a procedure, by a physician in the same group or in the same specialty. Because again, the patient has a complication or requires that extra service. And again, their own E&M codes are only reported when the patient presents for issues outside of the global package. All prenatal care is considered part of the global reimbursement. It is not reimbursed separately. Patients that seek care for routine illnesses such as cold, flu, and those are services unrelated to the pregnancy where you can use the E&M codes. Document and report those separately related illnesses using and bill for those using the E&M codes, as I mentioned here. Unrelated to the pregnancy, again, make sure you put the right diagnoses. One diagnosis code Z33.1 is diagnosis of pregnant state incidental. It is important that medical coding service provider is prepared to review, audit, and bill for E&M services. Your medical coders may ask you for the proper documentation because, again, they need that documentation to bill your claims correctly, especially services unrelated to pregnancy. Make sure you document very, very clearly so that your medical record coders can document that on the claim clearly and put the right codes on the claim. So remember, the global period doesn't cover everything. Services rendered during the global period of another service are often overlooked. Typical prenatal and postpartum visits are part of the global package. Examples of problems not related to pregnancy: yeast infections, vaginitis, STDs are not part of the global package. Problems not related to pregnancies may be billed separately at time of the service or treatment using E&M codes. Modifiers: 22 increased services. You could append that to your E&M code 24 unrelated E&M during postoperative period, 25 significant and separate E&M on the same date as another service, 52 reduced services. Modifier 59, a different session or patient encounter, a different procedure or surgery, a different site or organ system, a separate incision or excision, a separate lesion or a separate injury. Modifier 76, a repeat procedure or service by the same physician, and it's appended to your procedure code to report a repeat procedure performed on the same day to indicate that the procedure or service was repeated subsequent to the original procedure or service. 77, when a different provider applies the same operation on the same date of service, but it's a different provider. Okay, modifier 51, when multiple procedures other than the E&M service was performed on the same time by the same provider. Modifier 52, reduced services. Under certain circumstances, a service or procedure is partially reduced or eliminated at the physician's direction. You don't work with Medicare, so I'm going to skip this because this is a Medicare-specific modifier. Modifier 53, a discontinued procedure. That's usually a Medicare thing too. Modifier 58, stage or related procedure or service by the same physician during the postoperative period. Modifier 62, when two surgeons involved in the procedure. When two surgeons work together as primary surgeons performing distinct parts of the procedure. Modifier 66, when the services is performed by a surgical team. And modifier 78, an unplanned return to the operating room by the same physician or by another qualified professional for related procedure during the postoperative period. And modifier 79, unrelated procedure or service by the same physician during the postoperative period. Okay, this is just a repeat. Okay, I think we went through this. In bundling, one service is recognized as a primary service. Any additional services provided during the same session are included in the payment. The provider is paid only for the primary service. Okay, you've got to know your payer's rules on bundling is crucial. So even though we talked about the global bundling code, before you start billing it, call your insurance companies to say if they want you to use the bundling code or if they want you to use the CPT codes for separate CPT codes for antepartum, for delivery and postpartum care. Very, very important that you check with each payer first because they have their own bundling rules. Always make sure that the latest OB guidelines are retrieved from each insurer to avoid denials and short pays. Okay, I think